This past week, maybe a week ago or so, I got a call from a general dentist as a dad. He had a little boy, 3 years old, who's still mouth breathing. He talked about this because he wondered what he should do first. How should he approach this? The child's mouth breathing, but other symptoms are lacking. I mean, there's no major hyperactivity, there's no bedwetting, nothing jumping out at him but the mouth breathing. High palate and that sort of thing. So we talked a little bit about it because he was concerned as a daddy. And indeed, that is a concern, because a child does not develop as well if they are breathing through their mouth for many reasons. It's not just the jaws, that's part of it. It's also the amount of nitric oxide that they get, which only comes through nasal mucosa and sinus mucosa. When you're breathing through your mouth, you're not getting the nitric oxide. And nitric oxide is a potent vaso and bronchial dilator, so it helps really increase the level of oxygen that's available to the brain. So he was concerned, and he had a right to be, because the brain development is not going to be as great either. So there you go. And I talked to him for a while, and I had some suggestions. I'm going to look at my notes here, because he was going to turn 3 in 2 months. I couldn't remember exactly how. So he was 34 months of age, and he already has his primary second molars, which is good. No snoring, again, no real symptomatology signs other than the mouth breathing. But there's no question that should not be going on. Not on a regular basis, daytime and nighttime, for the reasons I just enumerated. So we talked a little bit about some of the issues. Now, some of the things that were concerns for me about this child were, number one, what is the tongue position like? And also, because when you're mouth breathing, your tongue tends to be low and forward because you've got to get air past the posterior aspect of the tongue, right? And we talked about the fact that, checking the frenum was one of the things I thought of that we should do. And another was the fact that a bluegrass appliance, even though there was no digit habit or anything like that, the tongue needs to strengthen and get up where it belongs. He asked me about taping, and of course taping has become a very popular therapeutic regimen in OSA, obstructive sleep apnea, particularly for adults and more for children, but older than that. In a 3-year-old, you can do it, but it's got to be addressed little by little, and maybe during the day a little bit, just for a few minutes here and there to get them used to it. But that's not my first line of therapy. That comes a little later. My first thought was, how about a bluegrass appliance to be able to give that tongue an exercise, a constant potential for play and strengthening? Because a tongue, let me tell you what happens in an airway kid. A child who's mouth breathing, for whatever the reason, is actually letting the tongue lie so low and forward, again, to get the air past it, that it becomes weak. It would be akin to putting a child's one arm in a sling from the time they were born, because this child's been mouth breathing from, the time they were born, he was born, and keeping that arm in the sling, take it off to bathe, take it off here and there, but for the most part, the arm is in the sling. By the time they're this little guy's age, almost 3, that arm is weak. That arm is not strong like the other arm. That arm is smaller. It hasn't grown as much. Muscular, not atrophy. It just never developed, you see. So now you have a tongue that is small in its muscle ability, but possibly spread out in its muscle position, because the tongue is a muscle. Low, forward, wider, pushing not where it belongs, up in the palate, to help the 2 shelves of the maxilla develop transversely, laterally, the way they should. But no, rather, it's pushing oppositely on the lower teeth and the mandible, although the mandible does not grow wider, the teeth get tipped out. There's not a real change in the cortical plates in the mandible, but in the maxilla, you're missing the growth. And so here you have the situation. I said, well, is there any hint of crust bite in the posterior? Any edge to edge? Any hint that there's not enough buccal overjet? No. He said, I don't think I see anything like that. I said, good, then we're not needing an expander right this minute, But how about, we may need expansion in the future, but how about you start with a bluegrass appliance, which is well tolerated after the first few hours tonight, and then the child gets used to it, and it's fine, and it becomes their tongue toy, and that's what we tell the child. This is your tongue toy, and you need to play with your tongue toy. Okay, so that was where we were going to start. So I sent him information about how to make the bluegrass, how to have the lab make it, even an idea of a lab that knows how to make it in case he needed one. I sent him photos. I sent him resources as far as how to have the appliance made. He does not normally band children's teeth. And 2-year molars are fine to band, by the way. 1-year molars, no. You can't get good retention on 1-year molars. But once you've got the 2-year molars, they work fine. So I talked to him about the fact that a good lab, and I gave him an option of 1 or 2, or actually 2, I think, that can do this, can fit the bands nicely on the models if you have a good impression. So we talked about impression, we talked about getting it, we talked about sending it to the lab, we talked about what to use, what adhesives I would recommend, and how to go about all of that. And we do recommend the Reliance line of adhesives. They're the best. Not only are they the best, but they're used by more orthodontic practitioners than any other adhesive for good reason. So we talked about that, and a light cure is wonderful because you have a little bit of working time, and then you can get that light on there and, cure it, boom. And so we talked about some of these actual technique things, and we also talked about his little guy and what to look for and what to expect and how to manage it the first day or two as far as since he goes home with the child. When we dentists do things for children or patients and send them home, we're not with them. We're not with them that first night after we took out the wisdom teeth, and they're lying there with I saw one cute patient of a patient with a cute picture, of a patient with a Coke can up against the cheek as a cold, we had recommended cold packs. So, you don't go home with those patients, and you don't know what they experience unless you or your children and your family members have been through certain procedures. Then you have one view, one patient, N equals 1. So it's interesting to be able to tell a doctor what to kind of expect, especially when it's your own child, because that helps you in talking to parents about their children when you provide the same treatment. So it was a wonderful experience, and you know what? He's going to change his child's life. This is what it's about. If you have a toddler, if you have an infant or a toddler, at 12 months, they should not be breathing through their mouth. Not ever. Not at all. They should have those lips together. I was reading about how the Native American Indian folks, and my husband's half-sister is half Indian, Native American, and we were learning that those mamas will often close the baby's lips after nursing if they see them open. That's something that their grandmothers taught their mamas taught them, and they teach their daughters. And mostly mamas, because that's who's breastfeeding, of course. So the point is, we need to be sure that our infants and toddlers are not mouth breathing. Not at all. That's the idea. So there you are, doctor. Now you know that you can look at your children, your nieces and nephews, the children of your friends, all the children in your life, as well as your patients, and really think about this mouth breathing thing. When do you worry about expansion? Well, you can do that in a 3-year-old. Do you start with that? Do you start with the bluegrass? These are things that are considerations that are in, by the way, the airway course that's online. But the point is, this is for you. This is for the children in your life, including your patients, that you care for. So call me, talk to me, let me know if you need any help with this. We're here for you. Good day.